Let's say that we have a patient that has more fat content than glandular content. So the glandular content, as we said, is going to be a little bit behind the nipple and areola, and then the fat content is going to be pretty much everywhere. So if we have a case of a patient with those characteristics, most likely, or maybe, doing good amount of liposuction will take care of all of his complaints in terms of contour. If he is a young patient, has good capacity of shrinking of that skin, then that's the most ideal intervention for that patient. If the content of the gynecomastia is, let's say, very fatty, not a lot of glandular tissue, but it's a lot, it's too much, then you start getting worried about, are you going to be able to retract, yes or no? Are you going to be able to shrink as much as I want to for you to not to have that loose skin? And as you know, we perform high definition liposuction, which is a liposuction plus, which is perform regular liposuction and then start edging the muscles, demarcating some anatomical landmarks. And when we do HD liposuction, we get a lot of skin retraction, a lot of skin shrinkage in the right patient. And so sometimes if we see that possibility, then we suggest them to, why don't we start by doing not only liposuction, but high definition liposuction, taking it to the next level and giving that skin better chances to retract and shrink than with regular liposuction. So that's why I was thinking, when we talked about liposuction, we have regular and we have high definition. We have used high definition several times on patients that actually are well built already. And the one thing they want is to have that muscle edging a little bit more clear. And we use that high definition liposuction on them. So applying or extrapolating those principles to pure gynecomastia, I mean, we've done it only and purely for gynecomastia high def lipo, and patients are really, really happy as well. It's actually great news, because in the past, when we were not doing that technique, if we would see that maybe the skin was not going to shrink correctly, if we were on that borderline, we would immediately recommend them to go into the other part of the world, other hemisphere, where we are going to start talking about it now, which is to go in and do a direct excision. So when the tissue is localized behind the nipple and areola, and you can feel it, and you can basically say, oh my God, I would just love to be able to help this patient, but just removing, just taking it out. That requires an incision around the nipple and areola, pretty much underneath. That's what we do, following that border between lighter skin, darker skin. And we make a small incision, mark the tissue that we want to remove, go ahead and scoop it out. And we have to make sure that we calculate this part, in which we say, do we think that the skin is going to be able to remold and shrink? And if that's the case, then that's what we should proceed with. We should proceed with just that little scoop out. Then you go into, what about if patients have a lot of tissue that it's not only localized, but it's it's expanding a little more. It's not only behind the nipple and areola. Well, you can do this same procedure, or you can add some other skin incisions to remove potential excess skin that could be generated after your removal. So then the incision is not only underneath the areola, but also sometimes has to come in a vertical form, or you have to go all the way around the areola to try to get more skin out, as well as you remove some of that tissue. And then you have the other extreme, in which you can, I'm going to ask you to either close your eyes, or we can look, you and I together, at some pictures of patients that really have like a male breast per se. It's not only that it's a little puffy, it's not only that it's a little bit big, it's a breast that even sometimes hangs. Mm-hmm. And in those cases, you have to do a technique in which we call it breast amputation, which is basically creating a large incision to be able to remove all that breast tissue, provide to patients with a flat chest, which is their goal. The price to pay is to have an incision all the way underneath the border, the lower border of the breast, and give them a flat chest, and then go ahead and do what we call a free nipple graft. So the nipple and areola, what we do is we shave it at the beginning of the case, we set it aside, we do the case, and once we have given them the flattest chest, then we go in and we use that as a graft, the nipple and areola. And so that's, I would say, the most extreme case for us to do that. We rarely have to do these cases, but when we have to, then we have the secret weapon to be able to resolve that. And one last, in terms of the techniques, is that we sometimes can combine the direct excision of a specific part with a little bit of liposuction. So also, and that's the reason why it's very important for me to be able to assess and individualize every single case.